Yep. All right. Well, thank you everyone for joining. Well, letting folks in as we go. My name's Candace Kinker. I am with the Coconino County Health and Human Services, and I'm also on the board of the Northern Arizona Alzheimer's and Dementia Alliance, also known as NAZADA. And I want to thank you all for joining us today for the Dementia Continuum, the brain testing and management, with Mike Miller and Sandy Ryan are here to present today. And I just wanted to make a quick announcement. NAZADA would like you all to know that our website will be launching hopefully within the next month. And we're really excited about that. And we really hope that that will be a useful resource to everyone. That will be at nazada.org, NAZADA.org. Right now it will show that it's under construction if you go to that site, but we will be sending out an email once it's up and running, and we would love to hear back from everybody on that. So Zoom etiquette, as we all know, please remember to mute yourselves. And as a reminder, we will be recording this presentation. So if you are not interested in being seen on the screen, please be sure that you turn your video off. And then also, I just wanted everyone to know, feel free to use the chat. I will be monitoring that throughout the presentation for questions, comments. If you have information or a website that you'd like to share, you're welcome to put that in there. If you're having technical difficulties, you're welcome to put a chat in there and ask me questions. I can't promise that I will answer them, but I will try. So just so you all are aware, as I said, we are recording this and we will be posting it to our soon to be developed YouTube page, hopefully within the next week or two. And we will also be following this presentation with an email to everyone who's registered with a link to that video that you're welcome to share with your families, colleagues, and anyone else who you think would be interested. All right, so with that, I will go ahead and introduce our two presenters for today. As I said, this presentation is called the Dementia Continuum, the Brain Testing and Management. Mike Miller is here with us today, and he began his studies in the brain sciences, learning neurosurgery in laboratory rats and primates. Fieldwork in primatology led to work in human neuropsychology. He was chief of Neuropsychological Services in the Department of Psychiatry at Rutgers Medical School in New Jersey. Using neuropsychological instruments, he studied brain behavior changes after head injury, stroke, brain tumors, Huntington's disease, and other dementias. After retiring, Mike and his co-presenter Sandy Ryan relocated to Flagstaff, where he is an adjunct professor at NAU. And Sandy Ryan is a speech-language pathologist who specializes in evaluation and treatment for people with dementia. Her career has included rehabilitation, long-term and end-of-life care. Her private practice focuses on home evaluations of people in all stages of dementia with attention to caregiver education and support. She is co-founder and chair of the Northern Arizona Alzheimer's and Dementia Alliance. Thank you, Mike and Sandy, for being here today.
Well, welcome everybody. I've never seen a Zoom with two presenters, and so this is a real adventure for us, but we'll bear with it because the wonders and the curses of Zoom are about to occur. And Sandy will take over.
Right, okay. So yes, welcome everyone. Thanks for joining us this afternoon. What we are going to be covering today is, first of all, just to let you know, not an exhaustive presentation on everything you always wanted to know about dementia, because we would probably need a week to do all of that. So we're going to be really kind of hitting the highlights, sort of the tips of the mountain peak, so to speak. What Mike is going to be doing is he's going to be taking the first 2/3 of the presentation, which is studying the brain. He's going to explain brain function, and going to be talking about the progress over the 20th century. Then he's going to be moving into neuropsychological testing. After that, I will be picking up on the management techniques and some suggestions for all of us. I also would like to say again that this lecture is not cutting edge neuroscience. Rather, it's the results of our viewpoints of what are some of the most important building blocks of cognition over the last 100 years or so. And with that, I am going to turn it over to Mike. And as he said, the curses of Zoom are about to occur. We're going a little bit above and beyond our ability level here, but cross your fingers and your toes, and this should work.
Okay, yeah, what I'm going to do now is start with the first thing in terms of why study the brain. And right now I'm going to take an excerpt from a Netflix program called The Surgeon's Cut. And I encourage everybody to take a look at it afterwards sometime. But in terms of inspiration to study the brain, this is Dr. Q, as he's called, and he's an immigrant from Mexico and has traversed many, many hurdles and is now chief of neurosurgery at a hospital. And this little clip shows you what inspired him to study the brain.
Tissue that could permanently damage his brain.
You got a good looking brain, Robert. Have you ever heard somebody say that to you? Saw a little smile there.
Here we go.
You doing all right?
When I was at Harvard Medical School, I walked into an operating room with a brain surgeon that was world famous. He saw me in a very late Friday night, walking the hallways, going to the library to study. And he asked me if I would love to go into the operating room. And as I came around the corner, I see the brain dancing, moving up and down with an amazing rhythm. And I felt that my knees were about to buckle. I had never seen the human brain with such a beauty, with such an amazing ability to dance with the heart and to imagine that that organ held the secret of humanity. That organ allows us to move, allows us to speak, allows us to see, to smell, to understand, to dance, to sing, to love. That was the key of the universe. And I felt something grab me. Every time I go into a patient's brain to remove a tumor, that brain is dancing. It is moving with the rhythm of the heart. my two hands are inside of that brain, moving in time, and I am dancing with the brain. I'm also dancing with the microscope, with my 2 feet controlling about 14 different motions. And I am dancing with the mouthpiece to control the focus and the magnification. So my entire body is connected to Robert's brain, and I feel at that precise moment connected to his soul.
Okay. Now I know that some people may not have been able to see the video portion of that. I can tell you that on my laptop, I don't get the video either. This is a little beyond me, but I can tell you that that was really just an introduction. As Mike said, you know, we refer you to Netflix if you have access to Netflix, and look for the whole series called The Surgeon's Cut. That episode was called Sacred Brain. Mike wanted to include that as just kind of a setup to what is so interesting about studying the brain. And with that, I'm going to turn things back over to Mike.
Okay, let me get to the right slide here. I have to do a little maneuvering here. I have to get the two.
Here. Let me.
Right, Sandy's gonna take over the control. Oh, there, she found it. Okay.
So I set this.
Yeah, we had to reset the slideshow. There we go.
Okay, we're good to go. Even though our backgrounds make it look like we're in very different places, we're actually about 2 feet away from one another, so I can jump in and help out, and I'm sure he'll do the same. So go ahead,
Okay.
Mike.
So the limitations of the brain are enormous, and the goals are fantastic. I mean, we want to be able to study what is the most complicated thing we know in the universe, which is the human brain. Luckily, every one of us has one. So that's very encouraging. But it's difficult for the human brain to understand itself, because all it has is to study it is the human brain. So it's a real philosophical and more than a physiological issue. For example, in terms of consciousness, we still don't know where consciousness lies in the brain. And that's really so fundamental into who we think we are. But, you know, as Descartes said, I think, therefore I am. So we must be using the brain somehow to have insight into ourselves. Now, brain sciences have enormously progressed the past 100 years, and that's what the scope of this talk is about. This machine was photographed about 100 years ago, and I'm sure there are many people guessing at what that machine is measuring, and it's not hat size, let me tell you that. What it is, it's measuring the bumps on the skull. It is the essentially the pseudoscience of phrenology. And then around the turn of the 20th century, early 20th century, this was the technique where we thought to study the brain was a good idea, and we thought that the bumps on the skull represent or reflect the surface of the brain. So while the concept was correct, obviously the details and the methodologies were incorrect. And so the 20th century was replete with numerous advances in the brain sciences, largely motivated by the results of the various wars we've had, and as survival skills in the battlefield enabled scientists to study survivors of the war, and especially those with head injury, and make correlations between what kind of a head injury a person had with what kind of a brain disorder was uncovered in the operating room. So they were really correlating head injury with a clinical examination of the behavior of the person that resulted. further on into the 20th century, physiological study of the human brain was possible, and they could, through a microscope, look at the cell structure of the different areas. And they sought to identify if different cell structure correlated with different functions. So already they were on the road to functional localization of the brain. And this represents the Brodmann studies, revealing different sections of the brain where the technology drove the further advancement of how the brain is organized. And even in the early 20th century, everybody was analogizing the brain to the technology of the moment. So early on, the brain worked like a telegraph, or then the brain worked like a telephone. And of course, all the way now, we certainly think it works just like a computer. But isolating the different cell structures really didn't tell the whole story. Very much like if we know what neurons are damaged, it doesn't tell us what the behavior is going to be like. It's like the blueprint that tells you what a house is going to be looking like, but not what the house actually looks like. So after a while, as advances in brain sciences moved forward, and we could study human brains to a only limited extent, you weren't going to start making a lesion in a human brain and making assumptions about what the deficits might be. But animal studies provided a suitable substitute of the time. And in the middle of the 20th century, I was doing a study in Puerto Rico on this lovely little island called Cayo Santiago. And on this island in 1950 something or other, or 1930 something or other, India donated 500 macaque monkeys, and you can see one of them sitting here in the foreground. This is on one part of the island. It's about a 40-acre island, so it's a pretty large island with 500 monkeys to be studied by looking at their natural social behavior. And our project led to what parts of the brain controlled this very, very developed social behavior in these monkeys. And so the head of the laboratory, I was just a postdoc at the time, the head of the laboratory was doing brain lesions in these monkeys. And then what we would do is return them to their original social group. And in macaques, these are rhesus macaques, in macaque monkeys, the social group has a very definite hierarchy. And so even though an animal is removed, if you put him back in the group as a normal monkey, he adopts his usual position. Well, what happened with these monkeys, with this one area of the brain that I'll talk about later, called the amygdala, when this was removed, this animal, or these animals, because there were several, would fail to rejoin their social group, and they would show no fearfulness of higher dominant animals. So after the surgery, their affinities to the social group were really challenged. They had no fearfulness, and they didn't recognize the threat of other monkeys. And what resulted is the animals would isolate themselves in remote parts of the island, as you see here, showing that this amygdala obviously had something to do with social affinity among animals. And what would happen to them, not knowing that they were not the dominant animal, they would be driven off by the higher ranking males who knew that they were the king, not this particular post-operative animal. So further into the 20th century, neurosurgery became much more possible because of the advanced technologies that I just alluded to. And here we see surgery for epilepsy. And the idea of surgery for epilepsy was to isolate the epileptogenic tissue in order to remove it. And what they would do would be to stimulate different areas of the brain, really to do two things: isolate the pathological tissue, and also to see if that area would interrupt very, very much to be protected areas like speech, language, etc. So this kind of surgery by the 1950s and 70s could readily be performed in order to avoid taking out tissue that would damage a very critical function in patients. Now it's been developed to an nth degree, and there's a very, very interactive process between the surgeon and the patient who is conscious at this time. And while it's a very serious procedure, sometimes you can make a little humor that relates to the process. If you can't read it, this leg is sticking up from this operating table, and this one surgeon says, "Whoa, that was a good one. Why don't you try it, Hobbs? Just poke his brain right here where my finger is." So they're having a little fun at the expense of their patient. So getting on to more near present times, ultimately the brain was able to be identified in terms of its total global map of functionality. This is the view with all kinds of coloring, you can disregard that, of the cerebral cortex of the human brain. And you can see, starting at on the right-hand side, the visual area, going up to the parietal lobe, and then the motor cortex, then the motor area, and then the frontal lobe. We see there's a progression from sensory processing in the back of the brain, the occipital lobe, and what happens when one area, the occipital lobe, gives way to the parietal lobe, the parietal lobe represents a higher order of complex processing. So the occipital lobe will process primary visual information such as light, etc. But if we want to make an association with other parts of the brain, you need a different kind of cortex. And then we move further forward where you have motor and sensory cortex, somatosensory, that really forms one unit. So what you feel is what you can act on very quickly, because these two areas are contiguous with each other. And then we have another association area which integrates different modalities, going all the way to the frontal lobe and the prefrontal area. The prefrontal area and part of the frontal lobe is what differentiates us from lower animals, including primates. If we look at an expansion of the size of the brain in humans compared to other mammals and primates, it's the frontal lobes that make the difference. And this prefrontal area is the area that makes the final associations as all the sensory information is fed forward to the area. And the areas that are important in terms of speech and language is the area here called Broca's area. Broca was a scientist in France in the 19th century who early on knew there was a relationship between language and certain parts of the brain. And he ran this hospital that was unique in Paris, where anybody who had a speech-language difficulty would be sent to Broca's laboratory. And of course, usually they didn't live very long because he was interested in studying their brain. But he became a real seminal force in developing localization of brain function. So once this was established, we got an idea of what parts of the brain control or are controlled by what areas of other parts of the brain in a very functional map. And if we look below the cortex, down here, we see that in the subcortical areas, there's a whole new set of structures and pathways that I'll talk about very briefly. First of all, these pathways are connected to different parts of the brain, and even in the cortex, you can see there are huge connections among the different areas, some larger than others. For example, just in the motor speech area, you see that there's this large pathway connecting an area of speech recognition, hearing speech and decoding it into language, and a large pathway going to motor speech. In other words, the production of language. So there's a functional relationship strongly demonstrated by different pathways beneath the within and beneath the cortex. And notice this is a drawing, these are drawings by Frank Netter, who was an eminent illustrator in the middle of the 20th century. And even then, as you can see right here, if you can't read it, it says biological intelligence, pointing to the frontal lobes. Back then, even in the 20th century, we didn't realize that it isn't biological intelligence for which the frontal lobes are famous. We now know that the frontal lobes are famous for identifying and encompassing an individual's personality. If you want to give an IQ test, the area of the parietal area and the association areas in the premotor area are more important for intelligence test performance. So it's really personality, and we'll talk about that further in a minute. So once we understand the structures of the cortex and the relationships between the cortex and the subcortical areas, we have to understand how are they connected. Well, it turns out they're connected by white matter pathways that are elaborately laid out from early embryonic periods, genetic development. And it's these pathways that determine the connection, the real essential connections of one side of the, one part of the brain to another. You can see it's not that they're helter-skelter, they're in very nice intersecting pathways laid out very nicely. And if we can look at a modern view of these pathways, all of these are highlighted by different kinds of dyes. You can see there's a regular branching out of projections that really connect most parts of the brain with another. And specifically, I think, and this has not been proven yet, but I think it will be, that ultimately how a person achieves the greatest number of pathways in a select area is probably a result of some specific genetic precondition, and determines how strongly one has pathways in one area versus another area. And it's been shown now that, for an example, in autistic people, they have huge numbers of pathways that are atypical from one area to another, and that perhaps underlies their behavioral differences. Another way the brain is organized is from the cortical areas, which represent the highest level of functional differentiation, down all the way through the thalamus and the medulla, pons, etc., into the spinal cord. So there's a lot of connections between the top and the bottom of the central nervous system, showing the great number of communications. In another way the brain is interconnected is the two hemispheres. And we now know there's a great deal of hemispheric differentiation, whereas in 95% of the population, language of various kinds is located in the left hemisphere, while the right hemisphere specializes in visual, spatial, non-language, musical kinds of processing. course, they're connected by huge commissures or white matter bundles. So any kind of function like language is mediated by largely the left hemisphere, but also other components such as prosody and pacing is regulated by the right hemisphere. And of course, motorically, we know that the right side of the body is controlled by the left hemisphere and vice versa. There's a crossing at a lower part of the brain. So that's a dimension that has been studied immensely in terms of having strengths or weaknesses after different kinds of brain lesions. Another developmental issue is revealed in this schematic, showing how each hemisphere specializes in its functions. And it's a process that goes on from birth, or probably even before birth, all the way to adulthood. And what happens is this hemispheric specialization begins obviously here, but only when simple cognitive functions are performed. And as language comes in, the hemispheres specialize in their respective ways, getting all the way to adulthood, which is probably maturation occurs in the early 20s, especially of the frontal lobes. We see that's when cognitive functions are most complex and most differentiated in the hemispheres. So if you have a lesion as an adult, you will lose just that function because that hemisphere or that particular area is largely going to be relegated to that specific function. If you have a lesion in childhood, you will have the possibility of a lot of neuroplasticity, so you can redevelop that function as the brain rewires itself over maturation. However, if it's severe enough, your functioning will never reach the adult level. So one doesn't have a choice of when your brain lesion occurs, but you can think of it in those terms. And I'm getting a poke from my associate here. Here we have a conceptual model of the nervous system as I just went through it. You have an input of information. You have the idea that one has to attend to information. You have to concentrate and have memory. And then whether it's linguistic or visual spatial gets assigned to the different hemispheres. Moving forward as to the frontal lobes, where more higher level concept formation, reasoning, and analysis occurs. And then the output is in the frontal lobes, where we either have a motoric component, a language output, a muscular output, or an inhibition. And that's one of the key roles of the frontal lobes, is inhibiting behavior that is inappropriate at the time for whatever the specific situation is. Now, notice we've gone all this way and I haven't mentioned anything that is critical to Alzheimer's disease, which is what our talk is going to focus on. Because Alzheimer's disease is largely centered around the issue of memory, at least at the concept where the beginning is. And here we now will deal with these issues in terms of localizing where memory processing occurs. You see it's in the deepest part of the brain through this midsection that goes through the cortex. And it's the hippocampus, which is this pink area right here. And lo and behold, we have the amygdala. We're back to the amygdala, which is juxtaposed right next to the hippocampus. And in human terms, the way we can identify or describe the amygdala, it's commonly thought as the core of the neural system for processing fearful and threatening stimuli, just what we saw in the monkey with the amygdala lesions, including the detection of threat and activation of appropriate fear-related behaviors in response to threatening or dangerous stimuli. That's a current definition of the role of the amygdala. The hippocampus is the part of this area. It's a huger area here, but most of the processing occurs right in the medial temporal lobe. And what it does, it takes information in, and there's a transformation that stores the memory in different parts of the cortex. So if it's a visual memory, it'll be stored in the visual area, etc., by the different modalities. So the amygdala serves a very interesting purpose, according to what I just said. You can see here when somebody comes upon a dangerous stimulus, the information enters through the optic tract, goes to a junction in the middle of the brain, then typically goes to the visual cortex, which interprets it as possibly a snake, which means it's something to be very concerned about by the amygdala. Well, by the time that occurs, you're probably past the snake by the time all of that processing occurs. But there's a shortcut that connects the visual area directly with the amygdala, saying, uh-oh, there's something there that's bad, even before you have a conscious recollection of what it is. And so that's one of the short circuits that contributes to fast reaction time. Back to memory. So, may I be excused, my brain is full. Brain, in terms of memory, which is in terms of what's being encoded and retained, the brain is never full. It may be slower and has less specificity of what it's remembering, but it's stored in the appropriate sensory cortex. And really, if you think about it, it's who we are. It's what we think of what we are because of what we can remember. If we don't have this long-term memory, this memory in general, we would live a minute-to-minute existence. And it's that kind of symptomatology that is the first symptom in Alzheimer's disease and other dementias such as head trauma. So we can see here that Alzheimer's disease starts in the hippocampus, the degradation of the cell structure in the hippocampus and the amygdala, and then spreads to the cortex and involves most of it, except the sensory motor cortex is largely spared. So even though Alzheimer's disease is going on and encapsulating much of the brain, late stage Alzheimer's patients have little or less difficulty with primary sensory motor functioning. But what happens as the brain goes beyond the hippocampus and the amygdala and involves much of the cortex, the higher processing centers of the brain, that's where cognitive behavioral difficulties are first manifested. And so what do we mean by cognition? Cognition is these functions: focusing and sustaining attention, differentiating that, encoding and storing, that's the memory part that I just spoke of. You have to organize that information, solve problems, and guiding into the frontal lobes, planning and goal setting, and transmitting or communicating information. Often we think, though, that a large part of the conscious recall of memory is really just giving a readout of what's happening subconsciously. And we know from lots of studies that a lot of our processing goes on subconsciously, and our conscious brain is just a readout of all that processing that we're not even aware of. And we still don't know where this consciousness, as I said initially, originates. So once we know that we're going to be measuring cognition How do we do it? Well, we know that with dementia, and to define dementia is these factors, you lose memory, language, visual, spatial, calculating ability, executive functions, which are largely frontal lobe functions, motor planning, which is the same, and very, very importantly, insight into our own abilities. And so this is the goal of trying to do testing to evaluate these functions and ascertain if is there impairment in the person's cognitive processing capability. To that end, when I was actively teaching, graduate students and I put together this cognitive testing battery. And what it is, it has all the functions I described above, from remote personal memory to delayed recall, on this testing form. And scaled scores represent from 1 to 10. So here we have 10 all the way down to 10, 10, 10, adding up to a total of 100. So 100 represents totally correct performance on each of the subtests. And what we're interested in is looking at the profile of a person's cognitive performance, giving us strengths and weaknesses that can be dealt with in what Sandy is now going to talk about in terms of management. And just very quickly, I'll give you a flavor of what this test battery involves. First of all, we have remote personal memory, which is just that. It's facts about your past, as schools attended, cities lived in, children's names, and specifics about where you last traveled and what you had for dinner last night. People should have a command of those basic things. Next thing is fund of information. That's acquired general knowledge about your environment, from like who wrote Hamlet, who invented the telephone. It compares acquired facts in contrast to personal information that I just spoke to above. Orientation is the examination of one's awareness of time and place, season of the year, name of the building you happen to be in, or the time of day at the moment. That's an idea, again, as I'm talking about in terms of insight that a person might have, either well performed or not. Attention. Attention is the ability to focus on an increasing series of numbers that are tested here. So you have to keep them in mind and in your short-term memory and concentration. It's the kind of memory that is at the moment. You don't store it and then try to remember it. It has to be attended to at the time while it's still in consciousness. New learning, that's inputting new verbal information in terms of a story or list of words. There's inputting from short-term into long-term memory. That's really a very early sign of Alzheimer's disease, is the difficulty doing just that. Construction represents a nonverbal approach in which you have figures to copy and draw and then come back and deal with them in memory. The next area of cognition is language, and that represents the ability to understand, produce language, and deal with processing of simple reading paragraphs and things like that. Abstraction and, I'm getting ahead of myself. Frontal systems involves the most complex kind of processing difficulties in which motor motions have to be replicated, and you have to be able to sequence verbal and nonverbal reasoning tasks, which I'll talk about in a minute. The next area is abstraction and problem solving, where we have to explain proverbs. For example, strike while the iron is hot. What does that mean? Or how are a poem and a statue alike? These involve various kinds of reasoning of abstract in nature. And then the last, and maybe one of the most important in evaluation of Alzheimer's disease, is delayed recall. The ability to recall the design that was copied, or words that were learned earlier, or a story that was first presented. And in other words, it's measuring what's been incorporated into long-term memory, both verbally and visuospatially. And an example here, I can't give obviously examples of everything, but an example of a figure to be copied is presented here. If you were a live class, I would have you copy this figure. And then after you copied it, I would leave it. And then you would have to remember what you copied, just to give you an idea of the nature of the test. Another task here is to sequence numbers and letters. So you have to keep in mind that 1 goes to A, and then A goes to 2, and then 2 goes to B, and 3 goes to C, and so on. Okay, so that's the nature of that complex task. And lastly, another of the most comprehensive evaluation tools is the task of drawing a clock. And you can see how it involves so many aspects of cognition, from language to visual construction, perceptual, spatial. You have to generate numbers, you have to be able to write, you have to execute the task, and you have to remember the task, which is set the hands at 10 after 11. So you can see the example here. In a normal person, has all of those cognitive components intact. A person in the mild to moderate stage of Alzheimer's disease would do something like this. So there's some spatial disarrangement. Although this person did get the numeric sequences largely in order, there are deficiencies in that product. So that's the test that we developed. And we developed it and tested it on normal elderly controls. And normal performance in each of these areas shows that scores are between 9 and 10. These are people with high school educations, no complaints of memory or cognitive difficulties. We compare that with a group of Alzheimer's disease patients in the mild to moderate stage, mid-stage, I would say. And here you can see collectively, they still retain, this is digit span, the ability to repeat numbers in the immediacy. That's still impaired a little bit, but it's pretty well preserved in comparison to the other area of cognition, moderately affected. You can see their remote information is poor, their funded information, they're not well oriented, their construction is the same, moderate impairment, language is impairment, the abstracting ability is also impaired. The real telltale is the new learning ability. They can't incorporate new information as a normal individual who would do it up at 9 or 10, and their recall after this short delay, usually it's a delay of about 15 minutes, shows that they recall very little information. That hippocampal amygdala connection is not operating sufficiently to encode information. And that really highlights the difference between short-term and long-term memory. In this case, the man is on the witness stand and he's being questioned, and he said, I should have included my stuff in my long-term memory, which I mistakenly inserted into my short-term memory. So we don't have the choice of where to put it, but in this humorous rendition, he's pointing out to the fact that that's why he doesn't know the information. So I will make the focus of the findings in the new learning and recall of information as the first stages of Alzheimer's disease. And Sandy is going to discuss now what we do in those stages when we see them emerge in a patient. And I have another representation here showing a patient, before he was a patient, artist, who liked to draw windmills. Now, I don't know if he only drew windmills, but it turns out that this was his pre-clinical condition. As he developed Alzheimer's disease, you can see that there's a diminution in terms of complexity, in terms of specificity, and obviously he seems to be remembering less of this nonverbal visual spatial task. And as the disease progressed, this is a subsequent drawing. You can see even less definition, less specificity. Still, there's some spatial arrangement. And as the disease went on, you see that he's now using verbal labels in place of being able to take a place. He can't put the green color in, he just writes green. It's all relegated to a crude production of a windmill with no spatial context that the first one showed. And the last one I want to show shows that it was just a fraction and a figment of his original picture, which was very elaborately illustrated. So that's the how we identify patients. This is some of their deficits and how we measure them. And now I'll hand it over to Sandy, who deals with the hard part. How do we identify the strengths and weaknesses, and then how do we manage them? You're on.
All right. Thank you, everyone. I am paying attention to time here, and we did want to leave a little bit of time at the end for questions and answers. So I will try to hit the highlights of my information. As Candace said in the beginning, you know, we will make this information available to you after today. So if you miss something, don't worry, we'll be able to get that to you. And so with that, we titled this talk the Dementia Continuum. And that continuum can mean many different things. And so as Mike explained, starting with brain function and understanding what's happening in the brain, that then moves to testing. Once the person has had some sort of neuropsychological testing and their strengths and weaknesses are identified, now how can we take that information and inform our management of that person? So I will take over the controls here, and again, fingers crossed, we'll see how this works. So I'd like to start with just some initial definitions, some things that I know that oftentimes people can get a little bit confused about. First of all, we've been talking about dementia and we've been talking about Alzheimer's disease. And many times we can use those terms interchangeably, but they really do mean different things. Dementia essentially means the collection of those cognitive skills that are being affected. I sometimes say it's kind of like saying the flu. Well, the flu can be GI symptoms, it can be respiratory systems. Some people say, think of the word dementia like the word cancer. There's pancreatic and lung cancer and all these different types of cancer, but they're all cancer. You can think of dementia as the collection of cognitive dysfunction, and Mike laid that out, and I'm going to be getting back into some of those things in just a minute. Alzheimer's disease is one type of dementia. So as this pie chart shows, Alzheimer's disease is the biggest piece of the pie because it is the most common. And that's why most people have heard of Alzheimer's disease, but perhaps not some of the others: vascular dementia, Lewy body dementia, Parkinson's, frontotemporal. I think those are becoming more well known as the diagnostics are improving, and just in terms of society, people are more aware of these kinds of terms. Again, it's a whole other lecture to get into the differences. I'm not going to be able to do that today. What I will say is, just to go back to a point that Mike had mentioned, the neuropsychological profile is actually very helpful in terms of that differential diagnosis when a person is early into their symptoms, to determine, does this look more like Alzheimer's disease or does this look more like Lewy body disease? The profiles are a little bit more different early on. As the disease progresses, then more of the brain is affected, which means behaviorally, day-to-day function, people are going to, in many ways, sort of look the same. So. There we go. Okay, the other thing that I just wanted to say is, again, the fear as everybody sort of enters their 50s and their 60s is, oh my gosh, I'm starting to misplace things. Do I have Alzheimer's? There's a lot of information out there right now. This chart comes from the Alzheimer's Association website, which is alz.org. It is my favorite go-to site for everyone to start learning about all of the different dementias. Essentially, what this chart shows is that typical age-related changes are, yes, you might forget an appointment. Yes, you might forget where you parked your car. Yes, you might forget somebody's name, but it only happens every now and then. When we start thinking about a dementia like Alzheimer's disease is when those kinds of things are happening all the time and the person can't eventually figure out the right answer. They're just absolutely lost. Again, the Alzheimer's website, alz.org. If you look up the 10 signs, it really very nicely lays out those signs. And I refer you to that. Now, I'm going to talk about stages, stages of dementia, stages of Alzheimer's disease, because there are a couple of different ways that we can look at this. Again, thinking of that idea of continuum. So the first way that we think about the stages of dementia, again, there's normal aging, changes that happen with normal aging. Then as those changes start to happen a little bit more often, now there's a diagnostic category called mild cognitive impairment, or MCI, if you've heard that term before. And then if all of those symptoms continue to get a little bit worse, then we start looking at the person potentially having a dementia, particularly an Alzheimer's dementia. The thing to remember about this is that normal aging, processing slows down, somebody takes a little longer to get things done, but they can still do it. MCI, those kinds of cognitive changes are happening a little bit more, but the person can still take care of themselves day to day. They can still do what they need to do, might just take them a little bit more time. They may be making more mistakes. Other people might start to pick up on it, but they're still basically able to take care of themselves. The key difference, and when doctors start to diagnose a dementia, is when those cognitive changes have progressed to the fact that the person is now having trouble taking care of themselves. That's the key difference. The next way we can talk about staging, once we're talking about a dementia, again, particularly in Alzheimer's dementia, is early stage or mild dementia, the middle stages or moderate dementia, the later stages, and that would be a severe dementia. The reason I wanted to put this in here particularly is because going back several years, there were 7 stages of dementia, there were 9 stages, there were 5 stages, there were all these different stages. And finally, I think many people in the field realized that all of those stages were not helpful and just really more confusing than anything. And so now we're just using 3 stages, early, middle, late. That's really all you need to know. The other thing I'll say about this is, as I start talking about characteristics, early stage versus middle stage versus late stage, if you are living with someone with dementia, or you know someone with dementia, you may look at some of these characteristics and say, oh, well, that sounds familiar. Oh, but so does that. Well, you know, is he early or is he middle? Don't get hung up on the stages, because there's a lot of individual variability here. And that can make things confusing if you get hung up on the stages. Really just use it as a guideline. For all of us, particularly healthcare, social service professionals, what I've distilled here is what I think are really the goals of management. When we've got somebody with dementia, what do we want to focus on to help that person? The first one, and I put this one first because sometimes it's really the one that's the most forgotten, and that is quality of life. The ability to participate in enjoyable activities, whatever that may mean. That's important for the person with dementia. That's also important for the caregiver and the family, and I'll get into that a little bit more. The next goal of management, of course, again, for us professionals particularly, is we need to be talking to the family, to the caregiver. What is that person's or those individuals, what's their understanding of dementia? What are their current stressors? Do they know what to expect? And what is our role in helping them find that? Of course, this is usually where most of the attention gets put. What is that person's day-to-day function? What do they need help with? Where do they need assistance? But then finally, the fourth is the compensatory strategies. That's what people like me focus on. Again, it's this concept of using strengths to compensate for weaknesses, and that can mean all kinds of different things. I would distill down, if you don't remember anything else from today's presentation and you are a caregiver or a family member, these are the two things I want you to remember. There are two keys that I think are absolutely crucial to understanding how to live with and help someone who's living with dementia. The first concept, people have called this knowing their reality, understanding their reality. What that means is that the more that we can understand what the person with dementia is experiencing, the more that we can see the world through their eyes, the more we understand maybe how we can help them. The second key that we all have to come to grips with is we have to learn how to adjust our expectations. As the person is changing, we have to change. We have to let go of the past, focus on today, be aware of what the future is likely to bring, but again, we really don't know. Okay, I'm going to talk very quickly and briefly, and again, you'll have access to this information after today. What does the person in the early stages of Alzheimer's disease experience? They're going to have some difficulty comprehending and understanding what's going on, what's said to them. They're going to be forgetting a conversation, an event. They're going to forget that they were supposed to do something. Key, as Mike said a few minutes ago, they are going to start losing insight into their own behavior, into their own abilities and where they need help. And this can become one of the first times that it's a real struggle. What I want you to realize is, again, look at the situation through their eyes. When they are no longer able to do what they used to be able to do, or they're just having a harder time doing it, how are they likely to feel? They're going to be frustrated, embarrassed. They may start withdrawing. Well, I don't want anybody to see that I'm having a hard time, so I'll just not do that anymore. They may become depressed or very anxious. They will possibly deny and try to cover up where they're having trouble. And then they're just going to get angry at themselves, angry at you, angry at the world, because they don't really understand what's going on. So how do we handle this? I titled these slides, What We Do, because this is the key. It's all about us and what we're doing to meet their needs. First and foremost, we have to slow down, which is exactly what I'm not doing right now. But believe me, when I'm working with someone with dementia or even just an elderly person with slowed processing, you would be amazed at how much more they understand when you just slow down a little bit. Use short and direct sentences. That means, let's get our coats on. we're going to the store. Not, okay, in about 10 minutes, I think we should get our coats on because then we've got to go to the store. But oh, nope, I think maybe we should go to the post office first because it's going to be a shorter. That is going to lose the person in early stages of dementia. You do want to keep them involved in things, and yet at the same time, you're becoming more supportive of their ability to participate. Write down important information using a whiteboard or a dry erase board, the calendar. I put on here, be aware of the Post-it note tsunami. Post-it notes can be helpful when they're used far in between and just a few when needed. When your house starts to look like there's a blizzard of Post-it notes, it's no longer useful. You want to continue social interactions. I'll say this many, many more times. Again, continue past hobbies, but you might have to adapt how the person was able to do it. Maybe they can still do it, but just with a little bit of help. Next. The middle stage experience. I'm not going to go through this long list, but basically language is getting worse. More difficulty coming up with words. The person may start substituting words, or they may start making up words that really don't make any sense to you. They're going to start understanding what is said to them very literally, which means they have trouble with sarcasm. If you're the type of person who has a sarcastic sense of humor, that could be a problem because they're not going to be able to understand, oh, she's just kidding. Oh, he's just joking with me. They're going to have more difficulty getting lost with time, with people that they haven't seen in a little while. They'll stumble with that. More difficulty with decisions. I have more assistance with IADLs. IADLs is instrumental, I think, activities of daily living. What that really means is driving, grocery shopping, bank accounts, those kinds of things. ADLs are dressing, bathing, feeding yourself, going to the bathroom. Again, the person may start really becoming a little bit more paranoid because they've lost that insight. I'm not the one with the problem. Where's my stuff? Somebody must be getting in here and moving my stuff around on me. That's the kind of thing that can happen. Responding emotionally, no lid. This refers to that frontal lobe dysfunction that Mike was referring to. The frontal lobes allow us to respond, but almost more importantly, they know when to put the lid on it. Bite your tongue, don't say it, not the time and place, not polite. What dementia does as it starts to move into the frontal lobes is the person loses that ability to inhibit. And that's why they're going to start acting in that sort of knee-jerk way. They're going to say things that several years ago they would have never said anything like that. That's the kind of thing that can happen. So what do? Again, slow down, adjust your expectations. We need to be focusing more and more on our body language to help them understand what's going on. But as their language is changing, they're having more trouble coming up with the right words. Read between the lines, look at their body language, try to figure out what are they really trying to tell me if the words just aren't working. I said avoid sarcasm, establishing a routine. The earlier that you can start to establish a routine, things happen at the same time every day with the same people, we go to the same places, that can be very comforting rather than every day is a new day. Don't point out their mistakes, don't argue, and don't personalize. This can be sometimes the hardest thing for people to learn, but it's huge. It's not their fault, and they're not doing this just to push your button. Late stage experience, obviously, many more symptoms. Person needs a lot more support, more confused and easily agitated, but still they will respond to social connections. One of the things that lasts, I think, until their very end of life is their ability to understand another person's body language and tone of voice. So if I come into a room and I'm rushed and I've got a bad look on my face and I'm short with my tone of voice and I'm not even looking at them, they're not going to be able to say, oh, she's having a bad day, I better back off and give her an extra few minutes. They can't do that anymore. So what they're going to see is, oh, this is an angry person. She's threatening. I don't like her. What am I going to do? I'm going to yell at her. I'm going to push her away. I'm going to throw something at her because she's a threat. That's the level that they're working on. So again, in the late stages, we're really providing all of the assistance, but these issues of body language, tone of voice, communicating face to face, assisting them at their speed, not our speed, can be really, really helpful. So to summarize, how do we change? We slow down. We try to leave our stress at the door and not bring it into their space. We use our eye contact, tone of voice, and body language. I always tell people, take the word remember out of your vocabulary. If you are starting a sentence that says, remember, yesterday we talked about this. Remember, you were going to do blah, 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 blah. No, they don't remember. That's the issue. So don't start your sentences with the word remember. Say, I remember last time we talked about this, we decided. I remember that trip last year to the lake. We had such a great time. For behavioral issues, and this is truly another entire lecture, when the person starts to act really aggressively, we start looking at what was the trigger. What just happened to set this person off? The more we can identify those, the more that we can maybe start to take out those triggers. And for the caregivers, you really need to be asking for help and being specific with what you need. Can you come over here and sit for an hour while I go get my teeth cleaned? Could you pick up something for me at the grocery store? Could you call your father on Saturday? He'd really appreciate it. That's helpful. And enjoying the little moments as they come. Those goals of management, again, the compensatory strategies, we try to find the strengths instead of the weaknesses. Next. The day-to-day function and the need for assistance. This is where we start talking about bringing care into the home or having the person live somewhere else. There's no right or wrong there. It's whatever works for that person and that family. The family caregiver, we need to be helping that person find their resources, planning for the future, and encouraging them to ask for help. And again, increasing quality of life and participating in enjoyable activities. Keep doing what you can do, even if you have to do it a little bit differently. I wanted to briefly mention memory cafes, and that's going to be in a sentence. On my next slide, I'm going to show that we have several resources. Again, these will be available to you. One of the new things that we at Nazada are really kind of excited about, and we've been participating in, is something called a memory cafe. If you Google memory cafes, you will find out what they are. They are small groups that meet in communities. Now many of them are virtual. And it's any kind of activity. It focuses on socialization, no right or wrong answers. It's just a way for people to get together and have a good time. And that is so crucial at any point along the way. And so with that,